Thank you for coming to our session on remote monitoring. My name is Jacqueline Davis, and I have my amazing co-chair, Dr. Jordana Hoppy. And today, we are going to be talking about some exciting projects that are ongoing in remote monitoring. By a little way of background, we all know that in response to the COVID-19 pandemic, there was a rapid shift to providing remote care, with some clinical encounters still taking place virtually today. In addition to pressures placed on our healthcare system during the pandemic, improving health in people with CF has also likely contributed to a decrease in clinical encounter frequency. Opportunities to incorporate remote monitoring into the CF care model exist, but there remain key unanswered questions about remote monitoring techniques, including feasibility and reliability. So with that, our learning objectives are here. Presenters will share experiences from multi-center projects studying telehealth, home spirometry, remote airway sample collection, and remote social needs screening with the following objectives. Describe ongoing efforts and increase opportunities for remote patient monitoring within CF centers, identifying barriers and facilitators to employing different methods of remote data collection and monitoring, and to propose future directions for incorporating remote monitoring into routine care. With that, we will welcome our first speaker, Dr. Clement Wren, who will be talking to us about a home spirometry project.
Well, thank you. Thank you, Dr. Davis and Dr. Hoppy, for inviting us to share our work. So today I'm going to talk to you about our project entitled ICUPS, or Improving Clinical Use of Pediatric Home Spirometry. I don't have any relevant relationships with this presentation.
People aren't hearing.
Oh, people can't hear? So by way of background, Dr. Davis already pointed out that telehealth has become a core component of CF care. Obviously, there was a huge spike of telehealth during the pandemic, but as you can see, from these data from the registry, at least up until 2022, there's been this sustained about 20% of encounters being telehealth. So, of course, what about home spirometry? Well, of course, objective measures of lung function are critical for the care of people with cystic fibrosis, and spirometry is the primary method that we use to assess lung function. Therefore, home spirometry plays an essential role in telehealth care of people with CF. But despite that, there are a lot of barriers to the clinical use of home spirometry. Amongst them are getting patients and families engaged and knowledgeable and about home spirometry, integrating home spirometry into existing clinical and data workflows, and also just defining the use for home spirometry in the clinical setting. So it was with that background in mind that we developed the ICUPS project with the global aim of increasing and improving the use of home spirometry in the clinical care of children with cystic fibrosis. And we had three SMART aims. The first was to increase feedback from people with CF and their families regarding attitudes towards knowledge of home spirometry from our baseline to 90% of by October 2024. The second was to increase the percentage of home spirometry data that was integrated into our current clinical workflow processes. And finally, our third SMART aim was to increase the percentage of remote care encounters where home spirometry can be utilized. I'll be very transparent and tell you that we're really still working on aim one, so don't have any data to share about that. So I'm really going to share sort of what we've done in terms of moving towards aim one, aim two, and aim three. So just a very brief overview of the methods. This was a multi-center QI project involving the Children's Hospital of Philadelphia, or CHOP, Children's Hospital of Pittsburgh, and Riley Hospital for Children in Indianapolis. We used the ZephyrX Mir Smart 1 device because that's the device that the CF Foundation distributed during the pandemic. Want to point out that we're using this as a clinical device, not for research, and we're using it in the real world. So we did not incorporate coaching. Obviously, we we worked with families in the clinic when we gave it to them, but after that, all the home spirometry done at home was uncoached. And similarly, because this is a real-world clinical project, basically interpretation of the data, quality control, and the use of that data was really up to each individual clinician. So we didn't use like a central overreading center or anything like that. And then we just applied pretty standard QI processes, including creating a key driver diagram, generating process maps, and then utilizing PDSA cycles. So this is our KDD. I'm not going to go read it in great detail, but as most people are hopefully familiar with them. Our SMART aims, again, are here. Our global aim is here. We identified these key drivers and then the interventions that we could do to improve these key drivers. And again, as with any QI project, you always have to prioritize and decide which are the highest impact. So as I mentioned, this is just one example of a process map using the swim lane format. So again, to orient people with that, right? That means that basically you've got each person or entity involved in the process gets their own lane. So we have like the patient and family, the CF nurse here in green, and the clinician. And then we just, from the beginning, this was a sick phone call process map. So it starts with a sick call and ends with a plan, and sort of just creates a flow. And then what we did then is we built these into our clinical workflow and into our electronic medical record templates. So this slide just shows the distribution of home spirometers in our project from February to September of 2023. You can see it kind of started slowly, and then we really ramped up. And we're actually up to 164 people with CF who have home spirometers. And it's not, and honestly, the biggest impact that allowed us to be able to distribute them was that instead of shipping them directly to families' homes and trying to get them to actually remember to bring it to clinic, we got them shipped to our clinic, and we were able to dispense them in clinic. Because I feel like you have to almost call families 5 minutes before they leave the house to tell them to bring their home spirometer, and then they still don't bring it. But yes, so we did successfully. By the end of September, we had a large number of people with home spirometers. So what did we do with them? Well, this slide shows what we created a tracking form to track the use and how it was being used for every clinical encounter. And this slide shows the number of tracking forms per month, shown in the blue bars, and then the cumulative number in green. So we're up to, as of August, we were up to 78, and we've actually had, again, more in September. So again, we kind of hit our distribution peak by September 23, so you can see that's when we really started ramping up. You can see like February, March, when there tends to be more respiratory illnesses, we had a big bump, and actually, like, nobody was sick or needed it in July, in the middle of summer. But we now have a fairly large number of clinical encounters where home spirometry was used. This pie chart just illustrates the types of encounters. You can see in this light gray wedge that the majority of them are actually for clinic follow-up. So you might see a patient, their FEV1 might be down a little bit, or maybe they're being treated for a pulmonary exacerbation. And, of course, the recommendation is that you want to check to see if the FEV1 has returned to baseline. And prior to using any remote monitoring, the way to do that would be have people come back to clinic in 4 to 6 weeks for a repeat PFT. So instead, that was done at home. You can see then that in the darker gray, 20% were sick phone calls. And then the other was really kind of just, other things. There's really no particular theme. Now, and as part of the tracking form, we really wanted to see, really, did it have an impact on clinical decision making? And as you can see, it did. In 71% of encounters, the data were used for clinical decision making. But that's still, it's about a fourth of the time where it wasn't used, and the main reasons were that the decision was already made on clinical symptoms. So if somebody has had a wet cough for 2 weeks, in a way that it didn't matter whether or not you knew what their FEV1 was, even if it was stable, you're going to give them antibiotics. And also because there were times when there was not optimal technique. So that's really kind of where we are so far today. So what we're going to move forward in the next few months. Some of the things we want to do is reduce missed opportunities, because when we actually reviewed all our patients, at least at CHOP, and now we're going to do this also at Riley and Pittsburgh, there were actually, we're still not, even though we have all these forms and things, we still need to improve our consistency in utilizing the home spirometer. I think the other big issue is that for as I said, we've got a large number of people with home spirometers, and they have done, and we've really accumulated a fair number of encounters. But really, when we look at it, only about a fourth of the people with CF who have home spirometers have used it, and so I think we need to really try to understand better what those barriers are. I mean, I know, like, for example, one barrier is that a lot of times when the parent calls, the child is in school, so you got to wait until they come back from school. So those are some of the practical issues that we're still working on. In the meantime, we'll acquire more data on the clinical use of home spirometry, and then the other really important practical clinical aspect is financial modeling, because right now we're using the home spirometry dashboard and all of this through a grant through the CF Foundation. But if we're going to be able to employ this in general clinical use, we need to also demonstrate that we can bill for this in a way that covers its costs. So to summarize, using fundamental QI methods, we have increased the number of children with CF who have a home spirometry and increased the use of home spirometry in remote care. Many of the processes that we have developed can be adapted by other CF centers seeking to implement clinical use of home spirometry. And as we dig deeper into those tracked encounters, I think we're going to also be able to develop some insight into where the home spirometry has value in the clinical care of children with CF. And then finally, in closing, I just want to acknowledge the many people involved in this project. First of all, funding from the CF Foundation and the ICUPS teams from the three places. I don't have time to list all the names. I do want actually to mention that Lucy Tan is a second-year fellow who really should have been an author on this abstract, but she started all her work like in May after the abstract deadline. But she really created a lot of the data that I showed you. So I want to thank everybody for coming, and I'll be happy to take some questions.
Thank you so much, Dr. Wren. Please feel free to come up to the mic or submit questions through the app. We'll be monitoring both channels.
Mike Powers from Portland. Clement, I mean, thank you for the spearheading this with your three teams, and we're all looking forward to more data. But are parents and patients involved with some of the decision making about how to roll this out? Who's going to get the spirometers? It just speaks to PDSAs about family feedback.
So we do have patient and family partners, but I feel like, part of the thing is that they're the ones who are most engaged. So, but when we talked about, we do have patient and family partners involved in advising all the things that you mentioned, Mike.
John Gaffin, Boston. I wonder if you could speak to any technical issues that have come up or the quality of the data that you're collecting.
Yeah, well, I mean, in terms of technical issues, yeah, there have been times when like we had to, we had a couple, we've had some times where the spirometer had to get, we had to replace the spirometer, or we had to, like the software had to get updated. You know, again, we intentionally chose not to try to look at the, like, specifically measure like the amount of quality spirometry, because I think again that would require somebody overreading all the spirometry data, which we could do, but we have chosen not to do that. So, and as I mentioned, there are clearly situations where people where the clinician determined that it was not that the spirometry data were not of quality. And again, I think we made that choice because again, in the real world, if you're going to go out into clinical practice, that's what people are doing, right? Because there's not going to be like a central overreader. Thank you.
Hi, Kathy from the University of Michigan. Just curious, I don't know if it was consistent across all centers or not, but how did you communicate the home spirometry in the chart? Did you do that, or
Yeah,
was it incorporated into the
that's a
EHR?
great question. That so that was put into the encounters. So the phone encounter state template.
So like part of the template text?
Yeah.
There's not like a discrete field or anything that you had built in, or did families upload to the portal or any of that?
No,
kind of-
no.
It was in the template?
Yeah.
Thank you.
Yep. Great.
One of the challenges with home spirometry is that many research studies have found that there can be a bias for either lower, sometimes some studies are finding higher values on the home device relative to conventional spirometry. I think it's amazing that you did a QI project where you're using this home collected data to actually make clinical decisions, but how did you reconcile that there may be a difference?
So we didn't actually try, so we did not. So in other words, we treat the home spirometer as almost like a separate device. So you have a home baseline. We don't compare it. We don't compare it to the clinic. So we've got a home baseline, and we compare improvements based on that. So precisely because of that problem, I think again from a clinical standpoint, especially uncoached, I think it's hard for you to be able to get home spirometry data that are going to be really consistently the same as in the clinic.
As a follow-up to that, there was a question in the chat about whether any of the home spirometry data prompted you to bring them into clinic to do PFTs.
Yeah, I think so. I don't have the exact number, but yes, there were a few cases where we did that. Yeah, definitely.
And then at what age did you start using the home spirometers, and were you ensuring the patients had reliable clinical PFTs before enrolling them?
Yeah. Well, it was we looked at anybody who was 6 and above. And yes, and so again, that actually kind of brings up, maybe I should have put this as a limitation or a concern. Again, there's definitely selection bias here because we are selecting for people, right, who we already feel are not only capable of doing spirometry in general, but also what we thought were quote good candidates. But that was like kind of gets to Mike's point. I mean, we kind of made that choice versus necessarily partnering with families as much.
Take a question over here.
I think this is great because it also opens doors for patients who live particularly far away from centers. I know the data is not great, but I sometimes end up using on those kinds of patients the peak flow meters. Did you compare the home spirometer and its performance to how you would decide things based on peak flow meters?
No, we didn't use peak flow meters at all in this project.
I see in your future directions, figuring out the financial side of things, billing is on your to-do list, as I think it is for many of us doing home spirometry projects at our centers. Did you do anything with submitting billing to
Not
kind of
yet.
test reimbursements? Okay.
Not yet.
And any tricks that you had for getting accurate heights and weights for the home spirometry measurements?
So we looked at so we looked at that, right? I mean, and the biggest issue isn't so much so. we're usually still seeing people within 6 months. So, and if you look at the impact of that growth, it's actually pretty small. So we had originally contemplated doing some like home height measurements, but we definitely ultimately didn't do that. But one of the things we realized that we had to build into our process was that you have to update that height in the device, or you will not, or you're going to keep getting the wrong value. So we didn't. So there were still some issues accounting for height. That's for sure. Oh well.
Nigat Mehdi from University of Oklahoma. Very nice talk. I think during COVID, we all struggled with how to take care of our patients. I just wanted to know, because we also did something like this, but not the Zephyr one. We had bought a cheaper one from just the leftover money from the grant, and we gave it to all our CF patients. But our barrier was that our respiratory therapists had to FaceTime each patient and then teach them to be sure they did it the right way. Did you guys have a consistent way of teaching them?
We did the
We use
teaching. We did the
similar
teaching in the
6+.
clinic. We did it in the clinic. We just when we gave it out, we did it in the clinic.
In the clinic
Yeah.
entry for
Yeah.
everyone?
Yes.
Okay, but this was during COVID and they were.
No. This is all post-COVID. This project started in 2022. Yeah, beginning of 2022.
Yeah, because we did do in COVID that we
Yes.
FaceTimed, we taught them how to do it.
Yes.
And most of them did do pretty good, but there were barriers. Some of them were not able to do a good job.
Yes.
Thank you.
And we have one final question in the chat. I believe you mentioned that the devices were paid for through the grant, but were there any that were broken by participants, and how was that responded to?
Yeah, we just used a replacement one. Yes. Again, so that's something that we have the luxury of doing. That would be a challenge, I think, in clinical practice. Yes.
Great. Thank you very much.
Thank you.
So our next speaker is Dr. Drew Paisley, who is a fellow at Cincinnati Children's Hospital, and he will be presenting on assessing readiness to the early implementation of self-obtained respiratory cultures for patients with CF.
Thank you so much for the opportunity to speak here today. So I will be presenting on assessing readiness to the early implementation of self-obtained swabs for patients with cystic fibrosis. And this presentation will largely be an introduction to the methods we've been using in our implementation trial for the study known as SWAB-IT. My main disclosure is that this project was funded by the CF Foundation, but I have no other personal relationships to disclose today. And here are my objectives. So first, I'd love to give the audience an update on the results from our first phase of SWAB-IT, which was a clinical trial comparing clinic-obtained swabs to self-obtained swabs for patients with CF. Second, I'm going to overview the methods we've been using for our clinical implementation of self-swabs into our routine clinical care. And third, I'll provide you with how we assessed our readiness for using self-obtained swabs at 6 CF centers across the country. And finally, I'm going to end with a brief update on our current progress with this implementation. So quick background, as many of you know, routine surveillance respiratory cultures are recommended for persons with cystic fibrosis. And for several reasons, there has been strong interest to provide more CF care remotely. And to help with this, we feel that SOS could represent an opportunity to improve upon remote patient monitoring practices and our clinical decision-making at remote visits. So the self-sample accuracy and benefit implementation trial, which we call SWAB-IT, was a two-part study, with the first part focused on the accuracy and acceptability of using self-swabs compared to standard clinic swabs, and the second phase of the study focusing on how we could actually implement this into our clinical practices. So if any of you are interested in the results of our first phase of SWAB-IT, I encourage you all to go stop by poster number 84, which is being presented by Dr. Jordana Hoppe. Briefly presented here, we looked at 155 paired samples of clinically obtained swabs and self-obtained swabs. On the left-hand side, we have our accuracy data, with accuracy defined in the green boxes above, where swabs had agreement for positive and positive samples on both swabs, or negative and negative results on both swabs. And our overall accuracy for detecting any CF pathogen was about 79% for the study, with a kappa value of a 0.583, which indicates moderate agreement between these samples. On the right-hand side, we have what's called a Euler diagram or a Venn diagram comparing where there was overlap in agreement between these samples. So for detection of any positive CF pathogen, we had agreement between COS and SOS 63 times. And when the samples didn't agree, shown on the blue side shows that there is actually a trend where self-obtained swabs were detecting a CF pathogen more often than a clinically obtained swab. So with these findings, we felt ready to move on to our second phase of Swab It, and that this would be appropriate to try to implement clinically. And we asked the question, can patients with CF collect a respiratory culture swab at home? And the problem we were faced with is that this is a completely undefined new process with potential for barriers. Our objectives were twofold. First, to prototype using SOS in real-world clinical care, and then to assess and describe any barriers that we encountered along the way. And our methods were primarily using quality improvement and process-driven data. Specifically, I'll mention we did not abstract any patient-level data or culture data in this phase of the study. To do this, we recruited 6 clinical CF centers from across the country, 4 of them pediatric and 2 adult, from a variety of regions and populations. And since we were looking only at process data and not patient-specific data, this was submitted and reviewed as exempt by our IRB. At the beginning, we asked each CF center to form a local quality improvement team of key stakeholders, and we recommended some of these roles as shown below. And this is what our study timeline looked like in the form of a Gantt chart. So at the beginning of the study, we developed a welcome packet with all of the kind of tangible materials you might need to get started, and we held a kickoff meeting. And we followed up that kickoff meeting with interval network meetings every 2 weeks in the first half of the study, and then every 4 weeks for the latter half of the study. At these meetings, we had a QI expert or specialist who was a leader for the study, and she provided QI education and coaching at each of these network meetings. And over the 7-month period from March to September, we've been implementing self-obtained swabs. And some of the data we've been collecting has been any process level data, as well as network learning and sharing of our QI tools along the way. And this was our overall implementation strategy, which we defined as network learning, iterative evaluation, and continuous quality improvement. And we repeated cycles of this throughout the 7-month period. At the beginning of the study, here's a look at some of the data we've been collecting. At the beginning of the study, we collected 2 surveys to try to get at the question, how ready are these 6 CF centers to actually do this implementation? So we wanted knowledge about QI capability, as well as any upfront major barriers that we might need to address at the start. We also collected process data, as well as network learning details using QI interventions, and then we had surveys related to clinician and patient acceptability of this intervention. On our QI capability survey, we got results from 19 respondents who were the key stakeholders from our initial network meeting, and we had involvement from a variety of clinical and non-clinical roles. And we found that the vast majority of our respondents had prior QI experience at their local institution, with 84% being either involved or significantly involved. We also found variable knowledge with specific QI tools. And so looking at things like smart aims and key driver diagrams, more than half of our respondents, more than 50%, had at least basic application experience with all of these different QI tools. However, there were a few respondents for each category that had no knowledge or very superficial knowledge related to some of these things. Our second survey focused on barriers and facilitators to implementation. And we were getting at the question, are there any major things that we need to address up front to start this program? Or are any of these 6 sites really not ready to do this and we need to take a step back? To help with this, we looked at the Consolidated Framework for Implementation Research, or CFIR, and a tool called the Pragmatic Context Assessment, or PCAT. And the PCAT is a 15-question survey that we were easily able to translate for the purposes of self-swabs. And it asks questions aimed at predicting barriers and facilitators. We felt that this was a useful tool because it's easy to use and it's a very time-efficient way to gather this type of information. So this is my best attempt at visualizing the CFIR for you all. For those who aren't familiar with the CFIR, it's essentially a glossary of context or terms that implementation or improvement researchers will use to describe what affects implementation. And so our PCAT survey asked questions about these 14 different contexts and 4 domains related to implementation science. And if you're interested in following along, I did provide a handout that explains some of these contexts in the app for the conference. This is an example of the type of questions we asked in the PCAT survey. So we would give a statement about a particular implementation context and ask the sites to rate if they agree, disagree, or were neutral, and then to rate how strong of an effect that barrier or facilitator would have on their ability to do this improvement. And what we found is that for these 6 contexts, the CF centers were unanimous that these things would have a strong positive effect on our success with self-swab implementation. So these were things like people here feeling that this change is needed and important for our patients, or the fact that these centers had really good open lines of communication with everyone needed to make the change, or the fact that self-swabs would fit into their existing clinical process as well. Similarly, 5 of the 6 centers identified these 2 factors as likely to have a strong effect as well. So the fact that that self-swabs fit into the policies and structures of their center, or the fact that it was aligned with their CF leadership goals. When we look at some of these more practical items, the CF centers were more mixed on items related to things like time available, space, funding, and resources, where half of the centers felt that they were neutral on having sufficient time to accomplish this, and half were neutral on having sufficient resources like staff, money, and supplies. Importantly, though, none of our tested contexts were identified as barriers to this implementation. And so at this point in the study, we assessed that we had 6 CF centers that were well prepared to use self-swabs in clinical practice. We had a mixture of both basic and experienced QI capability, which is good because we're going to be using a lot of QI methods, and we didn't identify any major barriers up front that we needed to address. And so we've been doing this project for about 7 months now. We're in week 20 at this point, and actually just wrapped up collection of data for swabbing last week. So I'd love to give you guys an update on where we're at with the project and the early process data that we have so far, but this is all preliminary. So at the beginning, we developed this high-level SOS process map, and we use this as a guide not only to collect our process data at each of these points, but also as a guide on how to direct our interventions. So throughout the study, we asked sites to submit weekly data related to the number of swabs sent or ordered, sent, returned, and then resulted by the clinical lab. And if there were any major drop-offs at any of these steps along the cascade, it would be a target for how we could implement some changes. At the beginning of the project, we had to identify several really practical resources that we needed to address with the project. So at the beginning, we allowed sites to select their own patients and use their own eligibility criteria. We needed to come up with a way of labeling self-swabs in the EMR and have a specific separate order for swabs in the EMR. We also needed to assemble everything that might need to be included in the kits. So this is a look at what our kits at Cincinnati looked like, where we had a postal pack, a bio bag, shipping labels. We included a cover letter in every kit with instructions, as well as a printed educational handout and a link to an educational video. Here's a look at the educational handout that we used, and this handout was actually made at the beginning of the Swab It study, and involved key stakeholders, including parent partners, on what was the best way to convey this information. And it had a link to a video which we produced with a patient of ours and a parent partner, which gave instructions on how to both collect and then return the kit to the CF Center. And so we are now at week 19 of this study, and this is our cumulative process data. So that's, again, the sum of how many we ordered, sent, returned, and resulted. And at this point, we've sent around 100 swabs to our families and resulted between 40 and 50 of them. And so we did find that our largest drop-off occurs at the number of sent to the number returned, which consistently was about 50% throughout the study period. In keeping with our QI methodology, we asked sites to try to keep track of the failure categories related to why there was a drop-off at that step. So this is an example of the Pareto chart that we use to identify where we were failing. And so we have a lot more work to do to summarize our learnings from this study, but I wanted to give you kind of a brief preliminary summary of what we've talked about so far. So at the beginning, sites were determining their own criteria for selecting patients. So some sites focused entirely on telemedicine appointments. Other sites were just aiming to get as many of these kits sent out and returned as possible. So we really just worked with patients who preferred to collect the swab at home, and we would give them that option. And then towards the end of the study, we actually started using self-swabs to follow up previously positive cultures without associating it with a specific clinic visit. Sites were generally very successful at sending the kits if they had been ordered. The main things that we learned here was that timing of kit delivery was very important for success if you were going to get it back in time to talk about at an appointment. And then using commercial services was, of course, associated with a cost. The greatest drop-off occurred at returning our samples to the clinical lab. And we felt that motivation and context may have been a really important factor here. So a lot of our population, we were sending swabs in advance of in-person clinic appointments, and that may have decreased motivation to actually complete the self-swab if the patients knew they were coming to the appointment anyway, that maybe they forgot about it or ran out of time and they had the opportunity to collect it later. But we did note that interventions were needed here. We had to address timing of kit delivery, confirming patient addresses, having clear instructions, and setting reminders. And then finally, communication between the lab and the CF team was imperative. And we encountered a major barrier if your lab is not ready to support processing home swabs. So we had one CF center that had plenty of experience sending and receiving sputum cultures, but their lab was not on board with processing swab data from home. And so that was a major barrier for them ever being able to send and receive SOS. So in conclusion, we felt that this project was important for unraveling a completely new process for self-swabbing, but we do feel that SOS is feasible for remote CF care. And the prototype implementation period of the study is almost at its end, and really the results of the study are going to be specific to having high institutional readiness for doing this and having a strong QI capability at your center. Moving forward with this project, we have a lot more work to do for data analysis and finalizing our findings. So we'll continue tallying our process data. We're going to look at the results of the clinician and patient acceptability surveys. We're hoping to do some post-surveys, including repeating that PCAT assessment, because we, of course, found barriers that may not have been predicted at the beginning of the study. And then we'll continue summarizing our QI interventions more formally. Finally, next step of this project, I think a future study could look to scale up SOS to a larger number of centers and then build upon any learnings we had from this phase of the study and target specific interventions up front. And then, of course, sustainment and cost are always going to be important questions with any kind of improvement project and are relevant here. I'd like to acknowledge our co-authors on this abstract, as well as all of the different teams, the key stakeholders, and QI leadership that participated in this study, as well as the CF Foundation, Kathy Sabadosa and Whitney Brown for their support. Yeah.
Thanks. Greg Fraser from Christchurch, New Zealand. Do you have any preliminary information about patient acceptability of remote testing at this point?
So we collected those surveys. I don't have the results of it from the implementation phase of the study. We did collect patient acceptability and feasibility data in the first arm of SWAB-IT when we were actually doing the comparative samples. And so this is the results of that survey on the right, where 100% of patients in that phase of the study were willing to do swabs at home if asked, and 91% said the collection would be easy or very easy for them based off of their experience.
Thanks.
Yeah.
Daniel Weiner from Pittsburgh. I'm just curious if any patients that did this at home would prefer to do self-swabbing in clinic. I know it's an anxiety-provoking procedure for a lot of kids.
We didn't ask that question specifically, but we had great feedback from families that did the swabs at home that they really appreciated it because it was a lot less stressful and it decreased their experience when they came to decreased the stress of their experience when they came to clinic later that week. Yeah.
Go ahead.
Hi, Jason Fulmer from Austin. More of a comment than a question, but so many of our patients don't produce sputum anymore. And then, but they do talk about at home, they have opportunities where they do produce sputum when they're in showers, things like that. And then the new care guidelines, even though, especially on the adult side, there's fewer clinic visits, still call for frequent sputum collection. So I think home sputum collection is here to stay. I guess my comment would be, as we learn more about this, it would be great if the CF Foundation could come up with some kind of best practice guidelines or something about the best way to do this, because a lot of programs, I think, just don't know where to start.
Absolutely. And I would comment back to that. I think the learnings from this study would help with having home sputum collection stay relevant as well. One thing that we learned from this study is if we had failures where patients never returned their swab collection, and then they came to clinic later and they got a swab when they came to clinic instead, we asked them to keep and hold on to their kit at home so that they would have that available to them later on. And we actually had patients that participated in the study twice where they already had the kit at home and they eventually did send it in the next time we asked for it. Yeah.
Dr. Brown?
Sure, Whitney Brown, Cystic Fibrosis Foundation. Love the presentation. Just wanted to build on what Jason said about, I think a lot of adult programs are accustomed to sending, or have become accustomed to sending empty cups with patients, for when they get lucky and they can produce a sputum. But there is always that challenge of mailing it in, who's going to pay for the shipping, it's time sensitive, et cetera, et cetera. And some labs, and I think you discovered in your study, are just not comfortable receiving specimens, at least swab specimens from home. But I just wanted to point out that there was if we do need to get into using more local labs, which has always been a little bit of a hesitation because CF cultures are to be treated differently. But there was our microbiology task force led by Lisa Saman that just published in the last few months, and it's in a micro journal, so I don't know if everybody keeps up with that literature, but in CMR, Clinical Microbiology Reviews, it is best practices for micro labs and how to handle CF respiratory cultures so that the precious specimens that we do get are handled correctly. So it might be something that we could send out from the foundation, and it could start some conversations with the labs, and maybe nationally we should start with Quest LabCorp at a national level and see if we can get some uptake and buy-in. And it's not all just about adding more and more costly things that the labs have to do, but some of it is like you probably don't need a grain stain in people with CF. We tried to sort of do a trade-off of what you do need and what's less essential. So look out for that.
Gavin Graff, Penn State. So I'm sort of concerned about the shipping. So if you do it on a Friday afternoon, does the sample not get there to Monday or Tuesday? And will that affect the results?
So the question is about the time of viability of collecting the sample and then having it processed.
Yeah, so I'm just pulling up our Pareto chart. That was actually really one of the biggest barriers that we faced, especially in the summer months. I think we had a bunch of failures around the 4th of July, around Labor Day, where patients would return their kits on a Friday. The internet network shut down over the summer. That affected things as well. So anyway, the date that you send out that the patients were asked to return the kit mattered a lot. If it got done on a Friday, it would get delayed and might not arrive back until a Monday or a Tuesday. What I didn't talk about here, but was done in phase 1 of SWAB-IT, was that we used a 72-hour time delay of the self-swab cultures to demonstrate transport mimicry and make sure our results stayed stable. And they did, which meant that in phase 2 of the study, we only wanted to process the culture results if they arrived back to the center in less than 72 hours. And so we used that as a criteria at our center when we were communicating with our lab whether or not they would run the sample.
Thank you.
And I guess this one is more for the pediatric side. If there was a different quality of the samples, whether the children did it to themselves or if their parents did it for them.
In phase 1, we did not find any differences, I believe, in terms of caregiver versus patient collection. And I don't know that we parsed that out in phase 2 well enough in terms of quality of sample. Yeah.
I also think for most of the pediatric patients, it was collected by the parents, I think, as opposed to themselves. I think certainly in that younger age group, it would be harder to get the kids to do it as they approach adolescence. I think then that's sort of a question of if they're willing to do it themselves. It's a great point. And then we have a question in the chat. Is there a cost factor involved in distributing the swab kits? Where did the funds come from?
So in this case, the project was supported by the CF Foundation and helped pay for the cost of shipping and receiving. At our center, we were paying for pre-labeling 2-day return shipping. So we paid for the cost to ship it to the family, and then the package we sent was pre-labeled for them to return it to us. And in general, that cost ranged somewhere between $25 and $45, depending on where the patient lived. So there is a cost associated with it. And we have not explored the question of reimbursement and billing related to that.
And then there's a question about how the samples were shipped and did they need to be on ice?
The samples were shipped in the bio bag, and we used standard red label swab kits. They did not need to be on ice, though.
And just a quick question, follow-up. How were they actually shipped? Did someone come to the home to pick it up? Did they have to take it somewhere? Because those are barriers as well.
Absolutely. So for us, we were asking them, we used FedEx, and so we gave them resources to help them find a FedEx drop box near them. That was a barrier for some families in more rural areas where it was still an hour drive just to get to the closest FedEx drop box. So that's something that needs to be explored. I believe at Colorado, you guys were using like a service where they would come pick up the kits.
So we also utilized FedEx and gave the family the option of either having it collected from the home or taking it to a FedEx office to give some flexibility around that return. And to the rural point, I think in rural communities, sometimes getting that pickup is more challenging. And we did identify in one family who we see who lives in North Dakota that they took the sample to the closest FedEx center, but it was rejected because it was not a site that would allow for those biohazards to be mailed. So that's also, I think, a key thing that we need to keep in mind moving forward is identifying which locations will accept those samples.
Thank you so much. I think we're at time.
Thank you.
Thank you. Perfect. And so for our next presentation, we will have Maura Harrison, who is a clinical social worker with Boston Children's Hospital, and she'll be presenting to us today on remote social needs screening and intervention, early results and lessons learned from implementation of the ILLICIT study at 2 large pediatric CF centers.
Funding for the illicit study was provided through the CF Foundation, and I have no other personal relationships to disclose. All right, so in terms of background, we know that social risk factors are conditions that impact individuals and their families and are often linked to poor health outcomes. There are many different types of social risk factors. Some examples include housing, food, transportation, utilities, internet access, healthcare costs, medication costs, income, employment, and education. We also know that for people with CF, social risk factors can impact outcomes such as lung function, nutritional status, and overall survival. Remote monitoring has been a growing focus in CF care, but there has been limited work on how to remotely assess social risk factors. And that brings us to the illicit study, also known as the Remotely Addressing Social Risk Factors Study, which aims to test the feasibility and sustainability of a remote social needs screening tool and intervention package in both adults and pediatric CF clinics from different US regions. And these efforts have been led by UVA social work extraordinaire Dee Dee Jennings, and lead PIs Dr. Juliana Bailey and Dr. Brian Garcia of UAB. And the 4 participating sites have been the UVA and UAB adult centers and the Boston Children's and Dornbecker pediatric centers. And participating sites have aimed to increase the percentage of eligible people with CF screened to 90% and increase the percentage of eligible people with CF who receive resources and social work follow-up to 85% by December 31st of 2024. So we're still in the midst of this project. In this presentation, we'll only include data from the participating pediatric centers. So if you're interested in reviewing the data from the adult centers, check out poster number 766. All right, so we began meeting regularly, having multi-site huddles in early 2023. And we started with a pre-existing social needs questionnaire that was developed at UVA for adult CF populations. We started by adapting the social needs questionnaire for use in pediatric populations, and we also developed a tracking sheet. The social workers from each site created an online resource library through Dropbox, which contained separate folders for education, food, healthcare costs, housing, income, employment, internet access, transportation, and utilities. And since so many resources are state-specific, we also had further breakdowns by state. And the decision was made that this resource library would be made available to anyone who completed the questionnaire, regardless of whether they endorsed a social need. And we received feedback from parent partners that this was an important decision, given that not every family might feel comfortable disclosing a social need to their care team, but they might want to review resources on their own. Each individual site created a process map for screening and intervention based on their specific clinic workflows. We used our QI tools of creating a key driver diagram, as well as a simplified failure modes and effect analysis. Our primary drivers were remote access, health equity, collaboration, advocacy, and spread. And we also sought feedback on the whole process from our parent partners. For this project, we specifically selected parent partners that had lived experience with social risk factors. Before we implemented the questionnaire, we first gave all our families a heads up that this was coming. At Boston Children's, we utilized our patient listserv to kind of let them know that they'd be receiving this questionnaire, why we were doing this, what they could expect in response. And then we started screening. So in early 2024, we incorporated screening into our pre-visit planning. The questionnaire was sent out to families prior to their clinic visit. At Dornbecker, they sent out their questionnaire through MyChart. At Boston Children's, we were going through a medical record system change, and we used email. We also created an informational handout that had a QR code to the questionnaire. So if a family did not complete it remotely ahead of their visit, when they checked into clinic, front desk staff handed them this informational handout, and they could scan the QR code to then be brought to the questionnaire on their personal device. And we engaged team members to ensure that the handouts were provided and explained. And at Boston Children's, we also sent the questionnaire to families of patients that were lost to follow-up, with the thinking that perhaps social risk factors could be playing a role in challenges getting to clinic. Unfortunately, none of these families completed the questionnaire, but some have since scheduled clinic follow-up visits, which is great. And this is what our handout looked like, and huge shout out to our amazing QI consultant, Rachel Gordon, who created this for us. There's an explanation of what the questionnaire is for, and then a QR code that brings families to the questionnaire itself. Data was collected via standardized tracking sheet and was submitted to REDCap for analysis. We continued to have routine multi-site huddles to share results, discuss barriers and adaptations, and plan for sustainability and spread. We used the voice of the customer tool to gather more feedback on various process steps. And sites continued to focus on improving screening rates and timely intervention through rapid cycle testing. At Boston Children's, we also, in June, implemented a paper version of the questionnaire since we weren't getting the screening response rate that we had hoped for through the online version alone. And this is a combined process map between the two centers, Dornbecker and Boston Children's, just kind of what our processes looked like together. So we sent the screening out electronically to families prior to their visit. Ideally, they completed it electronically ahead of time, but if they didn't, they were provided with that QR code when they checked into clinic or a paper version of the questionnaire. And then they either completed it during the visit. If not, we attempted screening at the next visit. If they did complete it and request assistance, social work provided intervention within 1 week. And then we rescreened in 6 months or earlier if needed. If they did not request assistance, we plan to rescreen in 1 year. These were the voice of the customer tool questions that we asked our parent partners. And for the sake of time, I won't go through each one, but just to highlight some kind of common responses that we got was, our parent partners really emphasized the importance of that we needed to clarify the purpose of this survey and how it could help families, making it clear that we were not just asking for the sake of asking. We also got feedback that less was more in terms of the amount of care team members that were discussing these needs with families in clinic. Folks tended to prefer starting the conversation with social work alone and then involving other team members as needed. And then we really had mixed responses in terms of people's preference for intervening immediately in clinic versus following up later by phone. In terms of results, so between the two pediatric centers, our two patient populations combined is about 460 patients. And this graph is looking at our first 14 cycles, which brought us from January to about mid-July. The dark blue is for Dornbecker and the light blue is for Boston Children's. So of our patient populations, a total of 30.2 were screened throughout the 14 cycles with an average screening rate per cycle of 18.7%. So we didn't quite reach those rates that we were hoping for. Both centers did have difficulty getting families to complete the questionnaire remotely. In cycle 14, that's when at Boston Children's we started using the paper version. We did see our screening rates really increase after that, but that's not reflected here. This graph is looking at the percentage of timely social work follow-up provided to respondents who requested assistance. And important to note that when I'm talking about social needs, that's used to refer to when patients both screen positive, meaning they answer yes to at least one social risk factor, and they also indicate an interest in assistance related to the social risk factor. So there was a final question on the questionnaire that asked, if you've noted any concerns, would you like to receive assistance? And this really emphasizes a collaborative approach that's reflective of patient priorities. So of all the people that were screened, 23% did request assistance. And of that 23%, 97% received a social work intervention within 7 days. Again, here the dark blue is for Dornbecker, the light blue is for Boston Children's. You'll see that Dornbecker absolutely crushed it and had an 100% rate of social work intervention throughout all 14 cycles. We had a little dip in cycle 8, and our N in that cycle was only 4, and 2 of those patients were Boston Children's patients. So really that dip just represents one patient that did request assistance, and then social work could not reach them by phone afterwards to offer support. This graph is a breakdown of each resource domain. So there was a total of 48 needs identified, 11 of which were related to food. And the dark blue represents when a resource was provided. Orange is when there was no resource available. And green is when a resource was declined. So you'll notice there's kind of a lot of orange in the internet access category, and that makes sense because the Affordable Connectivity Program ended during the project. Another example of maybe when there wasn't a resource available was in housing situations, for instance. I think any social worker in this room knows that housing is difficult, and sometimes there just aren't the right resources available. So sometimes maybe a family was dealing with housing instability but was already on several wait lists, and we didn't really have anything new to offer, but our hope is that they still felt supported by the conversation. So in terms of limitations, the survey is currently only available in English, which is a big limitation. Also, the screening currently requires informed consent for research. So when people are clicking the questionnaire link, they're immediately brought to this rather lengthy informed consent form. So if they were doing this asynchronously and didn't have a care team member there to explain that, I think they were a bit confused because they didn't think they had signed up for research. For those that were handed a QR code to complete the survey during clinic visits, we found that to be a bit challenging in the pediatric clinics when caregivers are often entertaining young children, sometimes siblings, and as we all know, those visits are very busy. And just worth pointing out that for one center, they were starting a brand new screening process, and at another center, we were changing an existing screening process. So from a QI standpoint, I think there are challenges with both of those scenarios. So in conclusion, in the initial implementation phase, the use of the remote screening tool yielded low response rates across the pediatric sites. Interestingly, the participating adult centers did have higher rates of completion. They screened about 58% of eligible patients across these 14 cycles. However, despite having fewer patients screened, there were higher needs for assistance identified among the pediatric patients. And across pediatric sites, food and education were the domains with the highest requests for assistance. And the types of resources that were most commonly requested at each pediatric site did vary. At Boston Children's, I think our most common were medication costs and education, and at Dornbecker, food and housing were the most common. And moving forward, PDSA testing will continue to focus on improving the screening process, optimizing interventions, and addressing limitations. And just a big thank you to the UVA Data Corps, our patient family partners, and the care teams that participated, and all their names are listed here.
That was a great presentation of really important work. I think it is really interesting when we're thinking about these lower rates of screening and possible reasons why. Thinking from the parent side, seeing something about research probably is quite confusing. I'm wondering, is that something that was specific to BCH, or did all sites have to have this research disclaimer?
Yeah, all sites did have to have it.
And what was the reason that this was considered research? Is it because that's just not the standard way of obtaining this information?
All the data was shared through REDCap. So the survey was a REDCap survey, and it went to UAB, who was the data core. So that's why And it was really the IRB, it took months for most of us to get this through. It delayed the project like 6 months. But they didn't call it research, like it wasn't really research, but you still had to put this informational thing that people had to acknowledge they read. And it added 2 full pages to the survey that people had to get through. So we coached them, okay, just go through those first 2 pages and click yes, I want to do the survey. Right, so that was a big barrier.
Yeah. Thank you.
And you mentioned that families had the option of opting out of social work sort of resources or contact after the survey. For families that did identify needs, how often did that happen, or were you able to connect with most of the families that had resource needs?
Yeah, that's a great question, and something we talked a lot about when we were starting this, because I think adult centers are more comfortable with that question of like offering people the choice of assistance, and it was a little less comfortable for the pediatric sites. It did not happen often, and when it did, I still took the opportunity to thank people for completing the screener and kind of acknowledge that I reviewed it and just in clinic offered them the chance. Did you have any other questions or concerns? We also, when planning for this, decided that if there was, a patient that we were very concerned about medically and psychosocially, we would still be approaching that as we would outside of this project with a psychosocial assessment. So that was kind of our thinking around it.
Good morning. Aya Mayo from Portland, Oregon. Thank you so much for sharing your work. I think we can all kind of agree that we are in a time where we just don't have a lot of bandwidth to do all the things that we want to do for our patients. And so I am very sure that there was a lot of hours and time put in by you and your colleagues. And could you talk a little bit about how you found that time, and then also, any plans to make requests for additional FTE and any advice you might have?
Yeah, I think that's one of the benefits of being part of a multi-site QI project is that it's something your center has is participating in, and you're kind of all in it together. I think that we just tried our best to incorporate it into our routine clinic flow and part of our practice. I think maybe the most tedious part of it was the data tracking, and that was maybe the most time intensive. I think it's great to do projects like this and have data that shows that people are endorsing these needs, and I think that can be used as leverage for FTEs, and this is why social work is needed when we can do projects like this and show that there really is a need.
And we have a question in the chat as well. Did your screening involve suicide ideation?
No, it didn't. So this was separate from the routine mental health screening that we do. This was really, this particular screener was just about resource needs, no mental health questions.
In some quarters, there's been pushback on the term social determinants of health. Did you encounter that, number one? Do you consider terminology in that light?
Yeah. We actually didn't have that terminology. I don't believe anywhere that was on the screener that patients were receiving, but I know that health-related social needs is a more acceptable term, and it's a great point. Yeah, I think moving away from that term and using health-related social needs is the way to go.
Hi, good morning. Elisha Burley from University of Louisville. Thank you for your work. I wanted to know if you had any thoughts or if you've seen anything about addressing these social determinants of health needs related to the patient or family coming to the center more and their health also improving, or if that might be a future consideration of kind of looking at that correlation.
Yeah, I love that. I think that would be a really interesting thing to look at, how people respond to this screening and how often they're seen in clinic. That's definitely not something we looked at in this project, but I think that would be really telling, and kind of that is along the same lines of why we wanted to screen these families that were on our lost to follow-up list, which unfortunately was a challenge, but yeah, it's a great point.
Was this study all done outpatient? And then there's a comment, wonder if you could get more completion if identified families inpatient.
Yeah, this was done only outpatient, but right, social work is seeing 100% of the patients that are coming to our outpatient clinic, so we're still catching those patients that are sometimes admitted, but actually our parent partner brought up that point that right, there are oftentimes more financial stressors and when there's an admission, so it could be really beneficial to screen upon admission. That's not something that we did, but I think it would be a good next step.
And you mentioned there was a higher response in adults versus pediatrics. Why do you think that, this was?
Yeah, not quite sure. I think definitely the busyness of the pediatric clinic visits did play a role. I think it's easier if an adult is presenting independently to clinic, even if they haven't completed this beforehand. Maybe they just have more opportunity to do that while they're in clinic and they're not chasing around young children. But I don't know, also at UVA, this is where this screening came from, so I think their adults were very used to it, and that probably played a role too.
Great, thank you so much.
Thank you.
Our next speaker will be Dr. Theta Hong from Seattle Children's Hospital, and she'll be presenting on innovations for home spirometry implementation in youth with cystic fibrosis, I-SPY, interim results from a multi-center quality improvement initiative.
Hi. Okay, can everyone hear me okay? Great. Good morning. My name is Theta Ong. Thank you to Jordana and Jackie for inviting me to speak today. It is my honor to represent my team and present our work, the results from our innovations for home spirometry implementation in youth with cystic fibrosis, or the I-SPY study. I do have funding from the Cystic Fibrosis Foundation by way of grants and travels support, and then all of the spirometers for this study were funded by the CF Foundation, as well as access to the platform. So when we think about spirometry as a whole, in-clinic spirometry is, of course, the gold standard to monitor lung function for people with CF. And think about all the things that you take for granted when you want to envision that point of care service. You know that you have the equipment, the environment. You can even hear the amazing respiratory therapist coaching that amazing breath to get those results, right? I mean, I think you don't even second guess what those results are going to be like, and you have that result left to talk and discuss with families to make that clinical decision making as a whole. And can you envision that world where we have that technology to be able to use and take it just as for granted if it was happening in the home with our patients and families? It's also, there's some urgency to this in that we know post-pandemic, we're not seeing our patients as much in person. So we just don't know. What's the quality of that service? What are the results that are coming on as part of this? And so it's imperative for us to figure out what is the capability of home spirometry. But it's tough. We tried it in the pandemic. It's really hard in kids. There's a number of barriers that you've heard in trying to engage in this kind of environment and space. And so we sought to conduct a multi-center quality improvement study to develop and test pediatric home spirometry services. I'm going to give you a really big overview first and then kind of walk you through more details about our general approach. So we had 4 sites, 4 pediatric sites from very geographically distinct locations, from Seattle to Boston to Vanderbilt, as well as in Arizona. And we are all, despite being geographically diverse, are all part of the Cystic Fibrosis Learning Network. And what that means is we are very used to applying a learning network kind of approach, or this learning cycle, and I'm going to walk you through this. So when we think about the point of care, this is all these moments where patients and families and care teams get together as a whole. But we can come together and co-design these services together, and the learning network is organized in a way that we can elevate our learning together, apply our quality improvement methods from these point of care moments, feed that back into our local processes so we get this high reliability, and elevate that knowledge to a shared network space, apply that best evidence for each patient back to the point of care, and the cycle goes on. And the real drivers of this organization is all of the collaborators in this space, bringing together the experts, our patients and families, our respiratory therapists, our PFT lab specialists, nurse leaders, quality improvement leads, everybody's on board, giving us this experience so we can benefit from each other's expertise and drive this learning cycle. So we wanted to take the same approach in a group of these 4 centers. And we did this in 3 phases. The first was our design phase. And we wanted to reflect on what was our current state and our experiences together. But we were looking not just from our clinical experiences, but also our research experiences. So we partnered with the Outreach study, which was actually a study that was being designed to look at home spirometry as a clinical trial endpoint. So really needed rigorous training and performance in order to make that happen. And we looked at our in preparation for that study, as well as other experiences throughout our sites, really identifying where can we learn from this. And I'll walk you through more details of our general design, but the idea was to get to the right kinds of change ideas that were going to make us move forward, and then test those. And figure out, what works in each of our individual centers overall as a whole. And then move forward into the progress and share that learning and figure out, are we really going to meet our SMART aim here? Okay, you got to brace yourself because I'm about to QI nerd out on you as a whole. The idea here is when you talk about barriers, there's a lot that goes on, and there's only so much you can do as a whole. Bruce Marshall told me once that we have to have ruthless prioritization of what's going on. So what we did was share all of our barriers as a whole and really try to identify what was both important, but also what can we actually take action upon. And so really trying to aim for this top quadrant of the quick wins. What can we actually achieve? And we applied this to a series of barriers together, and I'm going to walk you through this example of how we said, are we ready to take on home spirometry as a whole? So this is an example of us prioritizing common actionable barriers as a whole. So sharing our experiences, we're like, what are all the things that could go wrong as a whole? And so we ranked those together as teams and said, these are the most common things, but then also, can we do something about them? Are they important enough? Everything was important, you can see, but we could only do so much right now. And then one of the main things is, well, everyone loses their spirometer. So you have to give it to them. You can't mail it to them. You got to do this in person. You got to set this up in person as an example of that. In addition to a number of other barriers that we were like, we can actually modify some of these actions. And we went forward and we applied what we had learned from our clinical and our research experiences and said, okay, here's the most common barriers that we can take action on. What do we have of all of our experiences that can match up to say, here's the change ideas we need to start on as a whole? And we applied this to 5 components, thinking about how we handle home spirometry. So, or even how we handle spirometry as a whole. So are we ready to do this? How do we train to do this breath technique? How do we coach some of these results? How do we discuss these results as a whole with our patients and families? And how do we monitor all of these efforts that are going forward? And these were the prioritized change ideas that we wanted to test and adapt, that we moved into the action phase of our project, doing plan, do, study, act cycles. And our SMART aim was that participating patients in these services would achieve and maintain 80% technically acceptable lung function series from home spirometry. We wanted values that would make sense to us, that if you're doing these efforts, we can use this together. So that was our SMART aim goal. And we based our definition of technically acceptable on American Thoracic Society criteria, as listed here. So here are our results. We had 81 participants across our 4 pediatric sites that were enrolled. And teams shared a whopping 110 plan, do, study, act cycles. That's a lot of learning that was going on through all this time. And here's the participant over the time as a whole and the kinds of services that they engaged in. And I'm going to just draw our attention to this bar graph on the far left, which has our aggregate totals as sites. And so 99%, so almost everyone except one patient, everybody got their spirometer, but one we couldn't get onto the dashboard as a whole. And then 79% were able to schedule or complete coaching. We had to modify our definition of coaching because turns out not everyone wants coaching. We learned a lot of things along the way, and sometimes you have to wait for them to come back to clinic, and they may bring their home spirometer if you connect with them in time, and so then you can actually do a coaching event there within clinic, so we can learn that along the way. And then sometimes if there were results, sometimes there had to be results, but 68% had an opportunity to discuss their results with their provider as a whole. And then every site, and I just for variation purposes, actually was pretty similar in being able to offer these services in the same pattern. Okay, so did we meet our SMART aim? I'm going to draw your attention to the right-sided axis and then the green line, which is our run chart over time. So overall, for the percent of technically acceptable series, we did, by July, actually get to the point where we had 89% of those results were technically acceptable that were coming back to us as a whole. The overall median is the purple dotted line, which is 75% of the time as a whole. And then I want to reflect now on the bar graph. The bar graph is actually, what this represents is the big energy that it took among all of the teams to actually, so the number of series is reflected in the dark blue column, and the number of patients submitting that series per month is reflected in that process. So the number of patients ranges somewhere between, by the time we really got going from January to July, we have about 20 to 40 participants or so. And the number of series that these patients were giving us over time was about 60 to 120 as a whole. So really giving us results, all of those points of care where we could have learning about how do we get this to keep going. So here were our key learnings. Of all those things that we tested, among our sites, we were really able to identify that these were the most helpful tools for us. So there was information sheets about like what to expect. We use those videos like from an outreach study that were already created that we've said, oh, we need to share these videos so families can learn how to reflect back on that as a whole. There was other tools like staff onboarding, and it was like, how do you train multiple team members to do this process as a whole? Who needs to be familiar, practice with this technology, give them time, look at the dashboard, use the dashboard. What are all the features of this dashboard that we can use as a whole together? And then the workflows, and there was a lot of workflows that we had to think about, but some of them that really resonated were, how do we fit this into pre-clinic review? What is that in-person setup? You know, how much time is that going to take us to actually make sure that the patients know how to do that hybrid coaching that I mentioned before, as an example. And so now going forward, we're trying to identify what is actually sustainable in this process. We're assembling a package of tested tools and workflows for pediatric home spirometry services for you all to try, at your own centers. So you'll be able to see, what works for you and what adapts or not as a whole. We really need to dive deeper into the home spirometry experiences and resources. So we're partnering with Dr. Andrea Hartzler, who's at the University of Washington. She's conducting focus groups and interviews and surveys among clinical teams and patients and families to really identify what potential barriers and new facilitators we can have in this process. And ongoing, we're reviewing these submitting spirometry efforts during this maintenance phase to really understand, are we continuing to go down this trend of technically acceptable efforts? So in conclusion, teams successfully adapted pediatric home spirometry services at 4 sites in a rigorous learning network approach. Participants who performed home spirometry had overall high technical acceptability, rapid shared learning, fine-tuned family resources, staff onboarding, and workflows. Long-term participant engagement in home use requires ongoing interaction with clinic staff and resources. Big, big energy. And our next steps will explore barriers to sustainability and expansion. QI is a team sport. And I would not be up here today without the remarkable energy and enthusiasm and this fantastic community of all of these people pictured here and so many more. I'm also really thankful for the CF Learning Network and the CF Foundation for all their support. Thanks very much, and I'll answer questions.
Hey, Data, great work. Good QI, nerdy stuff too. I have a very practical network learning question about how you kept track of data from multiple sites. Did you auto pull this data from the dashboards themselves? Did you have teams submit data? If so, did you use REDCap? Just I think these projects are only as good as the data that we get, and sometimes if that data is not timely or if it has to be cleaned, it could sometimes delay things. So just wondering how did you real-time use data here?
Yeah, so we set ourselves up as individual quality improvement projects to start. What we did was to get around the data sharing aspect and continue to move forward, because there were definitely delays and barriers for individual sites to be able to share. I mean, I think similarly as Moira had shared, just like there's going to be delays in if you want to have a shared REDCap and partition all of that data out, and then it's research or versus quality improvement. So what we did was actually train our sites to say, here is how you can pull a report from the ZephyrRx dashboard that we were using. This is how we would go about step by step pulling this data to look at the data and then submit us the aggregate as a whole. And that's how we ended up getting around some of this shared information. It was still work and time that we had supported from the grant as a whole. So I want to recognize that a lot of these sort of messages of generalizability, we are not able to really comment on, knowing that these are local quality improvement, but we still wanted to focus on the learning that we had. Thanks for that question.
Thanks.
Dr. Ong, that was an amazing presentation. You have been a wonderful leader of this program. I'm honored to be a part of it in Boston. Something that you're alluding to repeatedly that I felt as one of the participating sites is just the big lift that this is to manage all of this data that comes into us between scheduled visits, whether they're in person or telehealth. Could you speak a little bit to what you learned about the time commitment, either by site or as a whole, to kind of make this program work so that others can think about that as they're launching their own programs?
Yeah, I mean, I think we are still kind of trying to amass everyone's individual site. We did, as we were going through this, sharing, I'll just give you we had a lot of meetings to share these PDSA cycles. And in each of those meetings, for example, if people were testing the process for setting up the spirometer, for example, we're like, how long did that take you? How as a whole. And, sometimes things took less time than we were expecting. So, maybe it's 30 minutes of time as a whole to set up that spirometer. I see Richard there. He knows from our site's experience as a whole. So, and different people, it's different amounts of time. Also, how many people you have doing the process as a whole. So I think that's another element that we learned. We have to have multiple team members doing this so it doesn't overburden a single individual as a whole. We also, the frequency that you're doing is going to influence time. So if you're asking, for example, one of our sites was we asked them to practice 3 times in a week, and that quickly fell off. Okay, that was just that is not going to be something that we're really going to be able to continue to do in perpetuity, because this data also comes back to you, so you have to sort of figure that out. And I think that, so we're also concurrent to this, going to launch another surveys, like try to understand like what is some of the feasibility of this. So that's part of our future learning. I think really giving people some kind of timestamp. So this is our experience. It took us about 20 to 30 minutes to do this. We did a coaching session, for example, at our institution with a Spanish language interpreter, and I think we thought it was going to take a much longer period of time, but actually wasn't as a whole. And so there was some learning in that, and it depends on, are you interpreting for the patient, or are you interpreting for the family member who's part of that and learning that experience as well. So again, there's this sort of shared experience that can help kind of define what are those timestamps, and then we hope that that'll all be assembled within that change package that I was talking about.
Theda, thanks for leading this work and involving us and many of us in this room. I think one of the questions I have, and it's collectively for you, but also for the group, everyone in this room is very invested and engaged in thinking about remote monitoring, telehealth. That's why we're here, to hear and learn about this. But what can we do as a community to tell everyone who's not in the room, who's making decisions around CF care organization, center organization, issues around, time, allotting staff, how do we take that message, and what data do we really need to show that these will be valuable things moving forward? And I'll just sort of ask, do we need to wait for the perfect, or can we actually come up with the good enough?
Oh, big question, Greg, that I don't have the answer to as a whole. I think that is part of that partnership, both hearing from our patients and families as well, that this is valid and useful to push on the larger policies and decision making as part of this, right? Like when you think about swab it, and the cultures, right? Not producing sputum, or there's anxiety or procedures that are going on, right? There's a immediate drive. I think when I think about home spirometry as a technology as a whole, there's still all these kinks that we're trying to figure out, right? And the level of system barriers in that process. So, for example, I think pediatric sites being reimbursed for some of this time and technology, that's so far beyond, right? We don't even in Washington State, we do not reimburse our respiratory therapists for telehealth visits. So we completely rely on a facility fee, for example, to support that work. Same thing with our social workers, but that's a different topic. And I think that so there's all of these places of pressure that I think we do want to be pushing upon, and what the right data is, we have to come together as a community to say, like, that is going to explain how we're going to, where we need to.
And just to build on that, I think promoting the value is number one, of course, but I think finding ways to reimburse is going to really help people feel that this is important, because we all should be, compensated for our time in that way. And it is, definitely hard in peds for that, specifically to those points that you just made. I think that also, the buy-in of the patient voice needs to be at the front of the table too. And then just a plug that from a registry standpoint, right? So a lot of the things that we're doing, we're also asking to give back to the national data set, and they have added things like home spirometry, and now they've added a field for home cultures into the registry to be able to look at these data points that are coming in other ways than they used to be traditionally. And it seems like the new registry 2.0 is going to have a lot more RPM capabilities to input those data. So I think seeing that more frequently, I think hopefully will also motivate people to use some of these technologies.
And so for our final presentation in this session, we have Dr. Hunt, who will be presenting on the expanded use of remote objective monitoring during telehealth visits for people with CF experiencing acute symptoms.
Thanks. Thank you very much. I know I'm between you and lunch, so that's not lost on me. So thank you for being here, and thank you for having us. I am just a representative of a very large team, so I will do my best to represent. This was born by the question of how could we utilize telehealth in a very effective manner to be better at diagnosing exacerbations that are being called in as sick visits that previously weren't being evaluated. So I have no particular relationships to disclose for this presentation. And it's already been discussed this morning that telehealth rapidly increased during the COVID pandemic. I think we're all very aware of that and had participated in it. And generally, it's very well accepted, even within my own institution. Most people find it very satisfactory or satisfactory in terms of their experience with it. There's a lot of variability in it, right? And that's a lot about what we're talking about today. There's variability in platforms, variability about how it's been used, certainly difficulties with objective data monitoring, a lot of what my co-speakers have spoken about today. And over time, as we've moved more to, I guess, normalcy post-COVID, our experience with telehealth services, has it waned, but it's definitely decreased, right? So we're only using about 20% of services now, and it's really, at least at my institution, become more of a service for people who are relatively healthy for routine sort of health follow-ups. And there's also a question of sort of the viability of the service, if it's going to be able to stick around from a business model standpoint. But bring into this question of these sick calls, right? So highly effective modulator therapy have certainly decreased exacerbations, but it hasn't made them zero. And I'm sure everyone in this auditorium has had a sick call, probably even this week, where one of your patients or family have called in and said, hey, my sinuses are a little worse for the last 2 weeks, and I think it's starting to go to my chest. Can I just get some antibiotics? And that is very common. I will say we'll have 2 or 3 of those a day at my institution. And the response to it is highly variable. It's dependent upon who's going to field that call, and even like the day and how I'm feeling and how busy I am might be determine how I sort of respond to it. And there's no objective data that we get for those sick calls. Rarely do we have the flexibility of getting people in urgently, unless if it's like very severe sounding symptoms, in which case we use the ER. And then there's a lot of variability. One, are these really truly exacerbations? And if they are they even being captured in the registry data, or are the people just getting sort of antibiotics thrown at them? So the question that Noah Lechtjen and a group of researchers at Hopkins and UPenn and Augusta, and then myself at Emory started to question is, like, could we utilize telehealth to really advance it and scale it up so that we can explore these sick calls in a very systematic way to diagnose and hopefully better our treatment aims for individuals. And so that was our goal, is to try to protocolize evaluation and treatment of persons with CF who are having increase in respiratory symptoms through expanded use of remote monitoring. You can see our specific aims are essentially to create a protocol initially and then to really scale that up with good, objective, reliable remote monitoring. So this is our methods. We realized that this would be a very large lift to implement in the entirety of all of our clinics. And so thinking of it as more of an implementation phase, we were looking at individuals who had a higher percentage of exacerbations who likely would need something like this in the future. So we were looking at the top 20% of people who were having acute exacerbations in the last couple of years to try to recruit in as a sort of a proof of concept. We were looking for anyone over the age of 6, and certainly we were looking for people who could utilize telehealth services, both technologically as well as, the factors of being in state. And then we made sure that they got some tools to have at least baseline tools in order to obtain some objective measurements. So everyone got a scale if they did not have one, oximetry, everyone got spirometry at their inclusion, and we also obtained some patient-reported outcome measures like symptom scores. And all of this was obtained during their inclusion. So the problem of potentially having discrepancies in clinic versus home spirometry, they had a home spirometry performed in clinic that we always were going to compare to. We also tried to protocolize how we would treat certain exacerbations if they fell into these criteria. And this was just the guideline that our programs came up to sort of follow, but it by no means is dogma. So I want to say, like, for example, if someone had a strong history of asthma and yet their FEV1 had decreased more than 10% and it really seemed like an asthma exacerbation, they didn't get IV antibiotics, they got treated for their asthma. But by and large, this was sort of the algorithm that we had chosen during our initial design phase to try to behold to. And then the other thing that I mentioned previously is there's a lot of variability in follow-up for these quote-unquote sick calls and whether or not they would come back in 3 months for their routine health follow-ups or if they actually got evaluated after a course of antibiotics was highly variable. So we were trying very much to try to increase the number of return visits that we got within 6 weeks. So the process measures that we decided to really hone in on were, can we actually get telehealth urgently within 48 hours of the clinic being called with these sick visits? Can we actually get reliable objective data during these telehealth sessions? And then how often do we adhere to the treatment algorithm? And if we trend away from it, why? So like any good QI project, and you've seen this before, each institution had to map this out, their process map for how would we even do telehealth urgently. And this was Emory's example. It's not meant to understand, but it was quite complex because we didn't really have a protocol at all for urgent telehealth visits. It had been something that we established more routinely. So we had to get a lot of stakeholder buy-in, of which you've already heard about today, physicians, the nurses, scheduling, the patients themselves. And there were a lot of unknowns that we had to sort of fill in to create even a protocol to begin with. And each institution had to do this because there were specific aspects, obviously, of each institution as to what was viable. We also came up with a number of protocols to try to, again, be consistent from institution to institution. I already pointed out the one on the right here where we had a consistent sort of guideline for how we would treat these symptoms based on FEV1 and symptom scores, but we also had protocols for how we would recruit patients into the Europa study and how we would even get them in the telehealth. So again, not meant to be specifically go through all these, but we had some baseline protocols before we started our PDSA cycle just through the design. Our first key driver analysis that we wanted to perform is essentially how do we get people to telehealth urgently, right? So our smart aim in this case was to increase the percent of Europa patients, or this cohort, who could be managed through a telehealth algorithm from 0, because again, at my institution, we really weren't doing this at all, to hopefully 95% by the end of the year. What we found is our primary drivers were very consistent amongst all institutions. Like everyone had to think about, well, what's the availability of telemed appointments? How do we even get objective measurable tools to our patients? How do we make sure that our care team members are aware that certain patients are in this cohort versus the general population? But our interventions were very specific to each institution, right? Because there were differences between all of us. So for example, for my institution, for availability of telemed, we ended up setting aside time on Tuesday afternoons and Thursday mornings where we could have a block for telehealth that someone could urgently be put into, thinking that that would capture most people within 48 hours. Other institutions needed to do more of a rotating or PRN sort of telehealth. And so that had to be institutional specific. At our institution, to sort of note who these individuals were, we used Epic, and there's a big blue tab that comes up so that nursing leadership can recognize who is in the Europa study. Others sort of kept a running log near their nurses that they could use. So again, you have to be very flexible about that. We have, at the time of this, approached 133 persons with CF to try to include them, of which 115 agreed and consented. I find that that's a little interesting to me because honestly, I thought this would be a slam dunk and everyone would just join because they were getting free stuff out of this. But it wasn't the case, and I'll speak about that a little bit more in the future. But essentially, what came up a lot is for the ones who didn't want to participate in it, they felt like, gosh, it just sounds like you're making another barrier for me. I just want some antibiotics. And so I'll talk more about that. So you can see our average age was about 30. 26% of our patient population thus far is from the pediatric cohort. You can see our breakdowns of sex, race, ethnicity. And then our spirometric values at baseline were quite broad in the range of 15 to 127% with a median or mean of 74. So what have we collected so far? So we've had 47 sick calls in of the 118 that we've recruited, recognizing that this is a sort of a prospective study for an event that we anticipate happening but don't know is going to happen. Of these 47, they represent 30 individuals. So some people have called in multiple times. 38 of those got telehealth visits, so about 80%. And reasons why they didn't, sometimes they were just too sick, and they were immediately referred to the emergency room, which was protocolized, but sometimes they just fell through the cracks. So protocol deviations were not uncommon. And those were things that subsequently on PDSA cycles, these institutions sort of worked on. And then sometimes people just canceled. They just either got better or they had technical difficulties, which is just an aspect of living with this remote monitoring. We were pretty good right out of the gate of getting people in quickly, which I thought was remarkable. So 97% of those telehealth visits did occur within 48 hours. So really strong there. But what we did struggle with, and what others have talked about today, is getting good spirometry. So our number is a little better here, but initially the first 1 or 2 months, we were only hitting about 50% of people who were getting spirometry at the time of their sick visit. So that actually ended up being another key driver analysis for us. So these 38 televisits, what happened? So about 2/3 ended up getting oral antibiotics, so maybe not a significant change, but 3 people so far, or about 8%, ended up going to get IVs and hospitalization. What I really want to point out, and I'm interested in, is that 4 individuals ended up just needing supportive care, or increase in sort of airway clearance. They didn't need oral antibiotics. And I find that interesting, not because it's a big number, it's not, it's only 10%, but because it's not 0. So I will tell you in my own practice, depending again on how busy I am, those 4 people probably would have just gotten antibiotics from me. But the fact that we were able to evaluate them with some measurable objective data, they were able to not necessarily be exposed to the side effects of antibiotics or the pressure of antibiotics. So I thought that was interesting. And then of those televisits thus far, about 80% have had routine follow-up within the 6 weeks. So something that we're planning on working on in the near future. So it was really helpful when we did have spirometry. You can see here the baseline for the 20 individuals who we had follow-up spirometry on exacerbations. There was a statistically significant decrease in spirometry that we found, and there was a trend towards it improving during their follow-up visits. But subjectively, patients also usually felt better, so 85% were thought to have improvement in their symptoms over time with the therapies that they received, regardless of their therapy. But I mentioned back to the spirometry being sort of difficult. So one of our subsequent PDSA cycles was specifically trying to increase the spirometry data that we were getting from 50 to 100%. And you can see, again, we had a lot of key drivers primary drivers rather, that were very general to all of the institutions, but our specific interventions had to be sort of institutionally dependent. So again, one of the things that happens is even when these patients are given spirometers at the time of their initiation, sometimes they lose them, or they don't have the right batteries, or they have a different app that's downloaded. And so a lot of our interventions were sort of aimed at how do we make sure that they have education about spirometry? Do we have the availability to have respiratory therapy on with us? Some institutions are able to do that, others are not. So those are the things that we're still working on. And it has improved. You may remember we were up to about 75%, but not yet 100. So what have we learned thus far? Well, one is, routing through a telehealth clinic is aided by a protocolized process. And I know you're thinking like, yeah, of course it is. We all know that. But redundancy, I think, is critically important in that process. So when we found that there was a key critical person that was involved from our scheduling, went away to a different position and we had a new scheduler, so much was riding on their shoulders that when they were gone, a lot of our processes sort of fell apart. So redundancy is really key and something that we think about now as we're developing our processes. Consistent objective data still remains difficult, and that's why it's so great that so many people are thinking about, so how do we get it both consistently and accurately? And then broad patient buy-in, specifically for this project, may still be a limitation. Again, most people were, 90% of our patients that we approached were very interested in this, but there is a subset who didn't find interest in it. And I think, further education and maybe even normalization, where we just eventually say, hey, this is just what we do in clinic, will be helpful to get everyone to buy in. And then finally, not mentioned on here, is like we, again, purposely started with a smaller proportion of patients within our clinic. Several of these programs, Hopkins, UPenn, Emory, and Augusta are all fairly large programs. And so scaling this up to, again, I may have 3 or 4 or 5 patient encounters a day that call in for sick visits, so to speak. Being able to have televisit for all of them within a given week may be very challenging without, more support. So with that, I do want to thank, again, I'm just a representative up here. There's so many investigators led by Noah Lexon at Hopkins and Gina Hong and Michael Ray at UPenn, and Kara Lee and Varsha Taskar at Augusta, and then my wonderful team at Emory, as well as, Peter McGazel at Hopkins. And it's, I do want to thank the CF Foundation for supporting us through this expanded use of remote monitoring. So with that, I thank you for your time.
Hello, great job. One of my questions was, I have two questions actually. One is from the patient feedback, did they mention the cost a lot and the time versus a phone call where it's free to them and takes a few minutes on their standpoint?
So yeah, that's a really good point. So for the ones who deferred even participating in it, yes, time was part of it. So it was like time, and another, specifically at my institution, there's one individual who's like, well, I already have a neighbor who can see me, right? And so that's sort of a one-off. The cost right now is not as great because the foundation is helping. So scales, the spirometers, pulse oximeters, they're all being given to patients, but that would be quite significant cost if we didn't have that. And then the other thing is having the flexibility of trying to get in within 48 hours gives you a little bit of flexibility for patients, but certainly if someone's very busy with work, that may make it more difficult.
Yeah, I meant partly with the cost of a televisit. Were you
Oh,
billing
I'm
for
sorry.
the visits or not yet?
No, we're doing televisits. We do bill for them. I have not personally heard back from any patients who were concerned substantially, who were at least included in this study. I can defer to any of my co-investigators, but not yet, at least. Yeah.
Just to piggyback off that,
Yeah, please.
were you billing for the spirometry at all? in
No,
addition
not
to
for
the telehealth?
spirometry. We only, sorry, maybe I didn't answer your question. So we only billed for the E&M code for the televisit itself. Yeah.
And then my second question, of the 4 that you avoided antibiotics on, do you know, did any of them later need antibiotics or get hospitalized?
I don't believe so, no. Now, we did have others who initially had avoided antibiotics, but I believe 6 of those ended up needing oral antibiotics down the road. But there were 4 who consistently stayed through that pattern without antibiotics.
Great, cool,
Yeah,
thanks.
thanks.
And did you get any feedback from those who avoided antibiotics? Were they happy with that outcome, or?
I don't know. Okay. Yeah, it's a great question. We should ask that, but I don't know. Yeah, that's a good question.
Have you explored asynchronous care model or visit types as a step in this process to potentially alleviate your burden of trying to get people in within 48 hours, and then also to sort of maybe increase buy-in, lower cost of reimbursement when it's billed directly to the patient?
Yeah, it's a very good thought. I'm going to steal that completely, but no, I haven't done that yet. But that's a really nice thought.
We're using them at our center, and I think it's working pretty well. And then it also gives you a standardized questionnaire, right, that's going to the patient that then can come right back to you, but then gives you some more of those objective markers that you're looking for that you can hopefully track a little bit more over time.
We do send out symptom scores before they have their televisit. We've had a lot of challenge with people filling those out. So I know several institutions, in their PDSA cycles have just started to do it with the patient when they're actually on the televisit. So again, it's just a challenge, but I love your idea.
Yeah,
Thank you.
Hello, Dima from Arkansas Children's. Did you use race-specific or race-neutral GLI equations for the percentage?
So I think we're all moving towards race neutral. I think for the specific equations, it would be whatever the Zephyr is utilizing. I think they actually do use race specific. I'll defer to anybody who's doing a lot with Zephyr.
I think their goal is to change over. I'm not sure if it's happened
Yeah, I
yet.
don't
At
think it
one
has.
point, it was not race agnostic, but the goal is to get there.
Which again is why we've only compared home spirometry to home spirometry or Zephyr to Zephyr. We're not comparing to our clinical because we've moved to race neutral.
That was an amazing talk.
Oh, thank you.
I just have one more question for you. So I'm curious about the people who had the telehealth visit but didn't have home spirometry versus the people who had the telehealth visit and did spirometry. Have you looked, or are you interested in looking at whether there are any differences in kind of the clinical decisions that were made in those two groups?
Yeah, this is a really good question. I don't know if we've looked at that yet, but that would be a very nice thing to look. Anecdotally, I can tell you one of my visits that we had that were urgent visits didn't have home spirometry, and we ended up treating as if it was a severe exacerbation just based on symptoms. And it was somebody who had pretty low lung function historically as baseline. So it's a great question. Does home spirometry really ultimately change what you're going to do? It's a great question. Something that we need to look at. Yeah.
Thank you so much.
Thank you.